Hello, everyone, and welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Debbie Churgai. I'm the Education Program Manager at the Melanoma Research Foundation. We are pleased to have you join us today for this wonderful educational opportunity entitled The Current State and Evolution of Immunotherapy Treatment in Melanoma. The goal today is to educate patients in the community about immunotherapy treatment, and you will hear both from a physician and a patient. Our mission at the MRF is to eradicate melanoma by accelerating research while educating to and advocating for the melanoma community. We know that education is critical for patients to make informed decisions about their care, and we are grateful to Genius for their generous support of this webinar series and investment in MRF's mission. A bit of housekeeping before we get started. We encourage you to use the Q&A box that you'll see at the bottom of your screen to ask any questions throughout the session. The information presented during today's session is for educational purposes, and so any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources we have available. Also, this session will be available for viewing later as part of our video on demand library, and I will share that link in the chat in just a few minutes. So first, we're going to hear from Dr. Kluger. Dr. Kluger is an internationally recognized expert on the disease she treats, melanoma and renal cell carcinoma. She engages in clinical and bench-based translational research with a focus on developing novel therapies. Her lab has been continuously NIH funded, and she has published in top-tier journals. She designs clinical trials with laboratory correlates resulting from her preclinical work, and she has been heavily involved in early phase development of immunotherapy regimes. Today, she will be speaking about the trials that led to improvement in survival in melanoma patients with metastatic disease and view the drugs that have been approved in recent years and the associated side effects. We're also going to hear from patient and advocate and melanoma survivor, Jennifer Thicko. Jennifer currently lives in Georgia with her husband. She has 2 children, a son and a daughter, who are both healthcare professionals. Jennifer is the operations manager for Aerospace Carbon Solutions, a division of GE Aerospace, and she has worked for GE for 34 years. Jennifer was first diagnosed with melanoma in 2010. She received several different treatments and has had numerous surgeries. Thankfully, she has been cancer-free for over 6 years, and she owes her survival to Dr. Kluger, Smilo Cancer Center, immunotherapy, her family, and her faith. And after Jennifer and Dr. Kluger talk, we will introduce you to our next guest, and then we'll have time for Q&A. Dr. Kluger, take it over.
Thank you, Debbie. So I'm going to share my screen. Please tell me if this is, if you can see the PowerPoint presentation. Can you see it?
Yes.
Okay. Thank you so much for that lovely introduction. And it's my great pleasure to be here this evening to talk to you about the triumphs and the challenges that we have with treating metastatic melanoma or unresectable melanoma. So I'm going to start off with a few fast facts. So melanoma is the disease of the relatively young. Median age is 45 to 55. And of course, as I get older, that just looks younger and younger. The incidence of diagnoses of melanoma is going up. So these are just little anecdotal data points that we have over here. So in 2003 in the United States, there were 54,000 cases. By 2017, it had risen to 87,000. And in 2022, it was already over 100,000. Now, that increase is due to 2 things. It's probably mostly sun exposure, but people have become more aware. So folks would go to their dermatologist and say, what's this spot and what's that spot? And both primary care physicians and dermatologists have gotten better at recognizing them earlier. So that's partially led to the increase in incidence, but it doesn't explain the entire picture because the incidence of metastatic disease, so real melanoma that we need to treat, has gone up as well. It's now the 5th most common cancer in men and the 7th in women. but the majority do not metastasize. So in 2003, it was a dismal period for us. All patients whose melanoma had spread and wasn't amenable to resection or radiation therapy or any form of local therapy, pretty much all of them would die. The incidence of death at the time was 7,600 per year in the US. By 2017, that had peaked to almost 10,000. And by 2022, it had dropped again to 6,850. And that's thanks to the new drugs that we have, and I'm going to be talking to you about that. We expect it to continue to drop. In actual fact, even though the new diagnoses and the incidence is going up, we think the death rate is going to drop substantially. So melanoma appears in the skin. If it's thin and in the skin, it's stage 1. If it's in the skin and a little thicker, it will be stage 2. Stage 3 means it's gone to lymph nodes, but still resectable. And stage 4 means it's gone further internally. So what I'm going to talk about today is only stage 4 disease, and I'm really only going to talk about immune therapy. There are other kinds of therapy, but those tend not to work for as long. And we just, it'll be too many details if I go through everything. So it's metastatic disease and immune therapy. So in 2004, my colleague, Dr. Chapman at Sloan Kettering, published a review in the New England Journal of Medicine, which is our premier journal. And this review summarized all of the studies that had been done up to that point for patients with metastatic disease. And I don't expect you to be able to see the little details on this table over here. But essentially, it wasn't for lack of trying. It was negative study after negative study after negative study. And so when I started seeing patients with melanoma in 2001, once it spread, I would sit the patient down and I'd say, Mr. and Mrs. Jones, we're really sorry. We will do our best. Approximately 5% of people might be cured from older drugs, such as high-dose interleukin-2. It's an old immunotherapy, and sometimes melanomas would regress spontaneously. But the likelihood was that most people would be dead within a year. The median survival at the time was a dismal 6 months, only 6 months. So we would say, please get your affairs in order. We're going to try our best, but you need to plan for the worst. And then that started to change. In around 2005, 6, 7, that number already was going up to 9 months, 12 months median survival. And I know Dr. O'Day was part of the very first revolution of immunotherapy with a drug called ipilimumab. So on this slide over here, I have a list of the regimens that have been approved since 2011. So in 12 years only, there's been this long list fairly long list of regimens that have been approved. And prior to 2011, there were only 2 regimens. It was a drug called dacarbazine and high-dose interleukin-2. So on the top, I have a list of drugs and regimens that are approved for a subset of melanomas that are driven by a gene called BRAF. Everybody who's had melanoma will have their tumor tested for BRAF. And if the BRAF is mutated, they can get certain pills. These pills work really, really well, but they don't work for a long time, most of the time. At the bottom half of the slide, I've got the list of immunotherapies. And when those work, they work really well. So the first of the immunotherapies to get approved was a drug called ipilimumab. And we'll talk about that shortly. Then a drug called pembrolizumab, followed by nivolumab. Then we started looking at combinations of the ipilimumab and nivolumab. And that was approved because it worked better than either the drug alone. There's an injection of a virus, an oncolytic virus called TVAC, which can work if there are lots of small lesions in the skin. And then a combination that was just approved a year or 2 ago of drugs called relatlimab and nivolumab given together. So I'm going to go through some of the data that led to the approval of these drugs. So the first class of immune checkpoint inhibitors immunotherapy was this drug called ipilimumab. Now, what you see over here is something called a survival curve. On the y-axis, you see the percent of the patients that are alive, and on the x-axis, you've got time. So the 2 arms that are of this trial that are in orange and blue had the ipilimumab or the anti-CTLA-4 contained in them. And the one in black was some kind of peptide vaccine that we thought at the time might be beneficial. And you can see that the 2 arms with the ipilimumab had approximately 20% of the patients still alive. You can see, can you see my arrow over here or the mouse? So 20% of the patients were alive after 2 years. And what's interesting is that this line over here is pretty straight. So the patients that were alive at 2 years, for the most part, remained alive for a long period of time. And this was the first time we saw anything that was remotely like that. So we're seeing an increase in survival from less than 10% to around 20%. And this led to the approval of this drug in 2011. And some of the patients treated on this trial remain alive and disease-free. And then at around that time, in 2009, we started looking at a completely different class of drugs called inhibitors of PD-1. And I'll go through the biology in really general terms in a minute. But the trial started, the first drug was called nivolumab. We gave the first dose at Yale. And what was really interesting about this drug was that all the patients with melanoma who had responded, in other words, there'd been shrinkage of the tumors, those folks all remained in response. So if you look over here at this table, time on study, there's a little plus after everybody, how long they'd been on trial. And the plus means they remain on study because their disease continued to respond. And we had never seen anything like this. And I don't know if Dr. O'Day remembers this. It was presented at our annual meeting in Chicago in 2010. They made us go into a little room on a Tuesday, and nobody else was interested except for a few immunotherapy geeks that were sitting, and some people from Bristol Myers who developed the drug. And we were sitting in this little room, and Dr. Schnall, my partner, presented, and he was almost in tears. He said, "We're on the verge of a revolution," and everyone thought he was completely bonkers. But we were very happy to prove people wrong. So the way these drugs works is as follows. This is a cartoon that kind of depicts what's going on over here. So in essence, we all make cancer cells every day. So what makes a cancer cell is that there's a protein inside that's abnormal. It's mutated. So these cells sometimes get swallowed up by other cells called dendritic cells. These are cells that kind of, they're the surveillance cells. They see something bad and they say there's an abnormal component in it, and they present that abnormal component to our main immune cell called a T cell. And the T cells have these receptors. You see where it says TCR. So the T cell receptor recognizes the abnormal component or the mutated protein, and then it starts to get activated. And then these two cells start talking to each other, and the T cell starts to make these tiny little bullets, and those bullets get shot out of the cell, and they can make holes in other areas and in other cells. So these T cells get activated, and then after a few days, a molecule called CTLA-4 down here comes to the surface of the T cell and starts interfering with the crosstalk between these two cells. So that's a negative modulator of the T cell. You see there are these tiny little arrows over there in yellow. So if the CTLA-4 is a brake on the T cell activity, you can inhibit that with an antibody. So you're putting a brake on the brake of the T cell, and you're activating the T cell. And so this T cell will then get activated, and it'll start to proliferate. In other words, make baby T cells, and they keep dividing, and they make more and more babies. And they swim around in the bloodstream, and they find themselves in the tumor microenvironment, so where the other tumor cells live. And in the tumor microenvironment, they encounter other brakes. So one of the brakes is a molecule called PD-L1 that's expressed on tumor cells, and it starts talking to its counterpart on the T cell called PD-1, and that's a negative stimulator or an inhibitor of the T cell, I should say negative regulator. And so you can see those tiny little minus signs there. So if you take an antibody and you block this interaction here, you again have something that activates the T cells. So anti-CTLA-4 activates the T cells, anti-PD-1 activates the T cells, but they do it in two completely different ways. Okay, so they're non-redundant pathways within the immune activating systems. So what oncologists tend to do, if they've got one drug that works a little bit, so 20% of the time, that would be the drug over here on the left, the anti-CTLA-4 or the ipilimumab. Then they've got another drug that works a little better, maybe 25-30% of the time. What do? We combine them together, right? Makes sense. In those days, in 2009, 2010, the bar was so low because everybody was dying that all you needed was a cartoon like this and one mouse model, and you could go into a clinical trial, and the pharmaceutical companies were willing to spend millions of dollars and take risks like this. It wouldn't happen anymore these days. So at the time, the only evidence that we had that this worked at all was one mouse model actually in colon cancer, not even in melanoma, and a whole load of theory around it, like you see on the little slide over here. And with that, we went into a clinical trial. It was our group and the group at Memorial Sloan Kettering, and we gave the two drugs together. Now, just to emphasize a little bit of the background on what we've done, the old-fashioned chemotherapy you see the timeline over here, 5 years. The curve the curve shows a survival of around 10% at 5 years. So 90% of patients had died within maybe 24 months of diagnosis of melanoma. Now take a look over here on the right. If you give anti-CTLA-4 alone, this is the big trial that was done. That's this gray line over here. You can see 26%, plus 26% of the patients are alive at 5 years. If you give the anti-PD-1 alone, you're looking at 44% of patients alive at 5 years. You give the two together, you're seeing 52% of the patients at 5 years. So we call this the tail at the end of the curve. We want that tail of the end of the curve to keep going up, 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 up. And our work isn't done. The Melanoma Research Foundation's work is not done. Patients' work is not done because we need you to participate in the trials. Otherwise, we can't cure cancer. So, but until we get to 100% of patients, we need to continue to try to push this curve up, up, up. The other thing that we learned is that there are measures that are really important to look at. It's not just what percent of patients' tumors shrink. It's also not only what percent of patients are alive after 5 years or 10 years. The other important thing is, what's the quality of life like, and how many people can go about and live their lives? So what you see over here on the pie charts on the left is the two drugs together, the nivolumab and the ipilimumab. Over here, you've got the nivolumab alone. So that's the middle circle, and the ipilimumab alone is the circle on the right. So the percentage of patients that actually responded was the smallest with the anti-CTLA-4 alone. It was intermediate with the anti-PD-1 alone, and then was the best with the combination. And the dark green over here is a new measure which we now call treatment-free survival. So people are alive, but also of therapy, going about living their lives. By far, there's a higher percentage of patients with treatment-free survival at 6.5 years among the patients who got the two drugs together. So even though the regimen with the two drugs together is really expensive, it's really aggressive, there are lots of side effects, we'll talk about that in a few minutes, it does enable a large percentage of the patients to have good quality time off treatment without being on chronic treatment. And that's a really important thing to keep in mind. There's a newer immunotherapy that was approved just 1.5 years ago called relatlimab. It inhibits one of those other brakes on the immune cells. And when you give the nivolumab and the relatlimab together, it's superior to nivolumab alone. So nivolumab is the PD-1 inhibitor. It's also known as Opdivo. So you can see over here is the progression-free survival curve on the top. That means how long it takes for things to regrow. And at the bottom, you see the overall survival curve. Now, the data over here aren't all that mature. That means that the trial is relatively new. But you can see that at 42 months, 48% of patients who got the one drug were alive, and 56% of the patients who got the two drugs are alive. But keep in mind that on this regimen, patients remain on therapy up to 2 years. It's not any kind of quick one and done. And we don't know how people do yet if we stop treatment. The data aren't available yet, but we should know sometime soon. So there's another completely different class of therapy that I wanted to talk about. And the reason to focus on this one is that we're expecting an FDA approval in the next few weeks. I don't want to say too much. So this is something called cell therapy, where we fight a patient's cancer with their very own cells. So every patient here gets their own treatment, their own drug. This is as personalized as it gets. So what we do is we find patients who have two tumors. They need to have at least two tumors, one that can be followed and measured, and one that can be taken out and resected. So that's what we mean by tissue procurement. That means we take out a tumor that's at least 1.5 centimeters in size. So that's the size of a nickel, basically, in diameter. So we take the tumor out and we send it to a central lab or we can do it. Some places have their own labs. We have our own cell therapy lab at Yale, but most places send it to the central labs. So at the central lab, they take the tissue and they take a tumor and they break it up into individual cells. And then they sort the cells out with various different fancy techniques. And they take out the immune cells from within the tumor cells, because the idea is that those immune cells that are sitting there right inside the tumor cell know that the tumor cell are bad. They recognize the tumor cells. They just got tired of fighting, so they become what we call exhausted. So if we can stimulate them with all sorts of growth factors and make them feel young again and make them grow and multiply and populate, maybe we can then infuse them again into patients and we can make billions of cells. So we take the cells out. In approximately 80-85% of patients were successful in doing it. Sometimes the cells don't grow. Then we stimulate them, we grow them, and we freeze them down. And then they get sent back to the hospital. But in the meanwhile, patient is brought in and they get high doses of chemotherapy. And the reason to give high doses of chemotherapy is because you want to get rid of all the bad immune cells, all these regulatory immune cells that don't recognize the cancer, or may even be inhibiting other immune cells in the body. So we give these high doses of immunotherapy, and we do that on what we call day -7. And then on day 0 is the day that we infuse the cells back, the patient cells right back into them. And after that, we give a drug called interleukin-2, which makes those cells, those baby new cells that are inside the patient's body, it makes those cells proliferate. Then patients normally stay in the hospital for approximately 10 days. The bone marrow recovers and they go home. So the timeline from number 1 all the way to number 6 is as follows. So, well, number 1 is just when we meet the patient and when we make sure that they're eligible and all of that. But from the surgery is normally done 3 weeks before day 0, which is number 4 over here. So 3 weeks over here, they're between time point 2 and time point 4, and then another maybe week and a half total to the end. So the whole thing takes approximately a month, and even after discharge, there is some recovery time. So what's interesting about this is what I'm showing you here on this slide over here. What you see on the top is graphs that show sizes of tumor. So the x-axis is right over here where it says 0, and these are the sizes of patients' tumor. Anything that's above the x-axis is tumor growth. Anything that's below reflects shrinkage. Anything that's in light green means it completely went away, complete response. And one of these people over here is Jennifer. That's really very personal, but it is what it is. Jennifer's on the slide over here. And in light blue just means that there was substantial shrinkage, but a few little things remained that can still be seen on scan. So you can see that a good number of patients had shrinkage. Approximately half had substantial shrinkage. And the little graph here on the right shows you how long the shrinkage continues. So here I can tell you for a fact that the person at the top here, the longest on this particular trial actually is Jennifer. So you can see that many of these responses are really durable because the x-axis is months. And they stopped collecting the data after 4.5 years. But essentially, most of the patients who responded initially and who got to this point continued to have a response. So what we know from this particular trial is that we took patients who'd had many prior therapies, not people who were just here getting their first therapy. If we do the cell therapy as the first therapy, the response rate is substantially higher because this therapy predated some of the other ones. So it was given before we had the ipilimumab and nivolumab, and we know response rates were good. It is a little complicated to do. It's a little difficult to do. And, Jennifer will give you more about the patient perspective, but it's doable. It's best if done in select centers because it's complicated and you have to have a whole team that's around and ready to come in and willing to come in on a Saturday night or a Sunday morning if there's a problem. And it requires a little bit of experience to give that interleukin-2 afterwards. But it's the first step in taking our patient cells for melanoma and invigorating them. But you can see at the bottom here, I've got a little bullet that we need better methods to manipulate these cells. And I think this is just it's version 1.0. But we're going to, in a few years, we'll get to version 5 and version 6, and this will just get better and better. And there are many ways that are now being studied to improve that whole process of making the cells in the lab or in the Petri dish. So we've made all this progress, and that's all wonderful. Are we done? I would say, unfortunately, no. So if we go back to our survival curves that I've been talking about all along, this is the proportion that's alive, and the x-axis is the survival time in months. Chemotherapy, targeted therapy at 5 years, small percentage, less than 10%. Ipilimumab alone, that was our first drug, 20%, maybe PD-1 inhibitors alone, maybe 30%. The two together were approaching 60%. But over here, what I have in this little dotted line is, should we be giving two? Should we be giving 3 drugs? Should we have better drugs? How do we do this until we get this curve up to 100% and completely flat? So what's stopping us from getting there? So I summarize the challenges as I see them. Those that are in red are things that we're currently working on at Yale, but there are many people in the country working on improving lives of melanoma patients, and other groups have other emphases. So with all the progress that we've made, 40%, 50%, there's a percentage that just don't respond to anything that we do, and we need new approaches for melanomas that are resistant to the methods that we currently have. The brain metastasis population remains a challenge sometimes. It's not as bad as it used to be. It used to be that 50% of our patients would die from brain metastases. Not the case anymore. It's probably more like 10, 15% at this point, maybe even less. The other thing is, I didn't talk about this. It's I think we're in an election year, so we need to think about cost reduction. We have to do something about the price of these drugs. Every time we give a patient ipilimumab and nivolumab, a year of treatment costs over $500,000. It's insane that it costs so much, and it's just essentially not sustainable long term. In Europe, it costs maybe 1/10 of that. So political year, to speak with you, think we got to all think as a society about how we address the cost from a global perspective, but also from a scientific perspective. So if we knew which patients which were the patients that were going to respond, we would just treat those if we had better methods to predict that. Otherwise, we're treating everybody, including patients who are less likely to do well. The side effects. So these drugs all work by stimulating the immune system. They don't stimulate the immune system only in the tumor microenvironment. They stimulate the immune system in other organs as well. I think you're going to hear about that a little bit from Jennifer. So we're doing a lot of work on controlling the side effects. And then the patients who have autoimmune disorders like rheumatoid arthritis, ulcerative colitis, Crohn's disease, things like that, they have a really hard time with these drugs, and sometimes we can't give them at all. And then there are other subsets of melanoma, uveal melanoma. I know the MRF has a huge effort on uveal melanoma, and mucosal melanomas as well. We need to make more progress over there. Those are less common, but still remain quite the challenge. So I'm going to conclude that, oops, I clicked the wrong button. So I'm going to conclude that the long-term survival for patients with metastatic melanoma is much, much better. Well over 50% of our patients do well for a long, long time, if not forever. It's still a little bit early to say forever. Most of the benefit is from immunotherapy. Most long-term survivors are not on continuous treatment anymore. They go and they live their lives. But despite this, we need additional interventions so that we could further improve the survival and get those curves up to 100%. There are going to be many regimens that will be approved both in melanoma and other tumor types. So melanoma in many ways has been the poster child for cancer. It used to be one of the most dismal of all cancers, but now it's actually one of the cancers that leads the way in terms of studies with immunotherapy. And for all these reasons, the MRF needs your help and your engagement. And I'd like to thank the MRF for hosting this, and also Dr. O'Day for joining us and for supporting it. So I would like to turn it over now to Jennifer Jennifer is a longtime friend. That's the way I look at it. She's going to tell you how we've known each other for well over a decade. Our children have completed high school and college and gone on to do all sorts of things. We used to see each other every 2-3 weeks, sometimes even more often. Now she's moved away. She's broken my heart, but that's okay. I'm just happy for her. She's going to tell you a little bit about her journey. So, Jen, take it away. You can start with immunotherapy and end up with cell therapy.
Okay, well, thank
Following
you.
the same format. Yeah.
And you're not done with me yet. So even though I'm in Georgia, I'm still coming back. My melanoma journey started well before I was diagnosed. I had a lump on my head, right about here above my right ear, that I had for years before that. And truth be told, many doctors looked at it. I even had surgeons look at it, and nobody thought it was anything serious, and we just let it go. Until I talked to my ear, nose, and throat doctor, Dr. Coffey, who said, well, it's itching, it's bothersome, let's take it out. And we did. And a couple of days before Thanksgiving, he called to say that it was melanoma. Nobody expected it. I didn't even really know what melanoma was at the time, because back then it wasn't as well known as is today. Truth be told, retrospectively, I would say that I got it from tanning beds, because I'm of that age that tanning beds were prevalent. And I remember this skin doctor telling me, oh, you should go into a tanning bed before you go to Mexico or whatever, because it's better to get a base than to get burned. And I did it a lot because we went on vacation a lot. So that's where I think it started. Once I was diagnosed, it was a blur. Endless tests, appointments. Many doctors gave me no hope at all. One in particular, I now refer to as the crypt keeper, basically told me to get my affairs in order. I didn't have much time, because at that point I was already 3B. It was here, and we later found out it was in 3 lymph nodes. I was really desperate because I had 2 young kids and a husband who needed me. Thankfully, with the help of my husband and GE, which had had experience with melanoma before with one of our executives, they led me to Dr. Arian, who did my surgery, and Dr. Kluger, both of whom I will forever be grateful. Sorry. My tumor was taken out days before Christmas. Dr. Arian cut from here underneath my chin and way down into my chest to make sure that he got it all out. He took out some 40 lymph nodes. It was horrible. There's 1,500 stitches. He did a fabulous job. But because of the timing, it was Christmas time. And I remember sitting at the Christmas table thinking, this may be it. This may be the last time I ever sit with my family. But fortunately, 6 years later, thanks to Dr. Kluger, who ended up taking it all over, I'm still here to talk to you all today. I'm sorry I'm getting emotional. I promised myself I wouldn't, but it's a long journey, and I'm very grateful to still be here. The surgery was extensive. As I said, 1,500 stitches. And then once that healed, Dr. Kluger thankfully walked in and took over. It was a long journey. I'm terrible at the science part of it. So Dr. Kluger, please jump in anytime.
Yeah, that's ipilimumab or Yervoy. It's the same thing. Yeah.
Yes, I did Yervoy first. Unfortunately, that really didn't do anything. I ended up getting it in my stomach, my right flank, which oddly I found about accidentally on my chart, because that was when they started putting your results on, and I happened to click and I went, oh, this isn't good. And I had it in my paratracheal. I had it my right flank, my stomach, 3 lymph nodes here, and my paratracheal, all told. So the Yervoy did not work. So then we added the Opdivo. Together, it still didn't, I still kept getting it wasn't going anywhere. Nothing was working. The two really left me very in bad shape. I had retinal detachment, or feared of retinal detachment, so I had to go to the eye surgeon quite a lot to have it checked. Emergency room a couple of times. I lost hearing in my left ear, so Dr. Coffey injected cortisone in there. And I have hypoparathyroidism now as a result. That said, it didn't work. So what options were left? Thankfully, Dr. Kluger put me in the immunotherapy trial, and it was the best thing that ever happened to me. I spent 3 weeks in the emergency room, and not in Smilo. It was a hard time because I didn't think that being 3 weeks in the hospital was going to be as bad as it was, but it was very isolating. I could only have immediate family visitors. I pretty much was confined to my room because I didn't want to be exposed to anything else. I had chemo. My hair started to fall out, and oddly, the hair falling out was the easiest part of it. I had expected it. I'd seen people do it. I had the hospital come up and shave my head, and that was the easiest part of it all. It was the isolation and the fact that I finally came to realize that I had melanoma, and it was serious. Up until now, I had looked at melanoma as an inconvenience. I would get a little testy before my appointments, but I'd go. I'd get my infusions, and I'd carry on. I would sit there in the hospital with the IVs in my arms, typing away, doing my work. I kept my family going, doing the normal stuff, because I didn't want it to affect my life or my children or my husband's. We just carried on. Now I had no choice. My daughter was starting college. I put the going off into the hospital because I desperately wanted to put her into college and get her settled without having to work to see any of it, to see me sick. Before she left, I wanted it to be as positive as possible. And to this day, I'm glad I did. It was a really hard time. I got the chemo, as I said, the hair fell out, and then I started with the treatments. I only got one treatment. Most people, I guess some hospitals give 6 people. I only could get one because I had a severe allergic reaction to it. The nurse happened to be walking by, thank God. I couldn't breathe. My throat started to close, and I started sounding like a goose. 25 people swarmed in my room, injected me with something, and within minutes I started to feel better. But I'll never forget, my husband walked in the room and the horror on his face because he didn't know what was going on. Eventually, I was released. I have to admit that I did kind of harass Dr. Kluger and the doctor that was there to get out, because I literally couldn't, it wasn't good for my psyche to be in there anymore. I went home. I spent about 2 months on my couch, literally sleeping almost 20 hours a day because my body was so drained between the chemo, the immunotherapy, the reaction. About 2 months later, I started feeling better. I went back to work. I started participating in my life again, and I've really never looked back. It's been 6 years now. To me, I'm cured. I don't ever expect to hear melanoma, that I have melanoma again. And I'm grateful. I looked at melanoma as an inconvenience. I still look at it as inconvenience until I went to the hospital. I just barreled through it. But I had a lot of support. I had Dr. Kluger in my corner. I had Dr. Arian. I had GE. I had my family. And I had my faith to get me through. And I think that's what got me through. I am very grateful for the immunotherapy. But for that, I wouldn't be here. I am more than happy to answer any questions. I am more than happy to be, for any patient to call me if they want to talk one-on-one about it. It's been 6.5 years. I feel great. I am 61 years old. There are some side effects. I can't attribute it to the cell therapy. I have arthritis in pretty much every single joint. I don't know if I would have gotten that otherwise. I have the hypoparathyroidism, but other than that, that's all I have. And I'll trade that any day to be alive. Both my children are in healthcare. I don't know whether that's because of me, but I'm hoping that they can follow in Dr. Kluger's steps and make a difference, because she has. So thank you.
Thank you, Jen, for sharing that. So,
Yes, thank you so
Mhm.
much, Jen.
thank you. So while we wait for people to ask questions, can I ask you a question?
Sure.
Which was harder? The IV therapies in the clinic that went on and the side effects, or this big whacking that you took that took 3 months or 2 or 3 months until you recovered?
The IVs.
Harder.
I'll do the immunotherapy. I'll sit in the hospital for 3 weeks and recover for 2 months any day. I have over having to go, I think it was at one point every other week for infusions. That was
Yeah.
difficult.
Mhm.
That was difficult. And not knowing whether it was going to work or not. My final trial, the immunotherapy, was kind of my last chance. I don't know if there were other things available to me, but I'll do it again in a minute.
Not sure I would, but that was traumatic when you had that. So I'm just going to share that I was on the soccer field with my son when Jennifer had that reaction, but I left the hospital about 5 o'clock for some game. And I had an uneasy feeling because she had a fever before we even started to give her the interleukin-2 component of the therapy. So I had a very bad feeling that something was going to go wrong. So I asked one of my colleagues, Dr. Hurwitz, not to leave until I got back into town because the soccer field was like 45 minutes away, and thank goodness he was there. It was pretty scary.
Very, very scary. Very scary.
Yeah, but then it was
again,
over after that. It was a long time ago and it was over.
Right. And it really only lasted 5-10 minutes. It just felt like an eternity. And I was lucky. Only one treatment of it is all I needed. Now I'm told that other hospitals did 6 at the time.
Well, we try to give 6. We also, we just, with you, didn't want to take the chance again. Yeah.
Right. And thankfully it worked. So 6.5 years later, I'm here to tell the story, and I am living my life. I'm sitting in Seattle working. I travel, as Dr. Kluger knows, quite a lot for work, and it's as if it never happened. And I'm happy to see I'm at the top of the chart.
Yeah. Woman of the world. Okay.
Thank you for
So
sharing your story. But before we move on to the Q&A, I just want to introduce Dr. O'Day, who will be joining us for this Q&A portion. Dr. O'Day is the Chief Medical Officer of Agenus and a globally recognized clinician and thought leader in immuno-oncology. A pioneer in CTLA-4 inhibition, Stephen played key roles in the advancement of cancer therapies, Yervoy and Epidivo, and has been the principal investigator in more than 200 clinical trials. Prior to joining Agenus, he was executive director of the John Wayne Cancer Institute and cancer clinics at Providence St. John's Health Center, and director of the Melanoma and Cutaneous Oncology Research Center. Stephen was a visiting scholar in philosophy and medical ethics at Oxford and received his MD from Johns Hopkins and was a fellow at the Dana-Farber Harvard Cancer Center. So thank you, Dr. O'Day, for joining us. We have a few questions that are coming in.
Yep.
But my first question, I kind of want to ask Dr. O'Day. I want to know, can you just tell us a little bit about your experience at the forefront of these groundbreaking immunotherapies?
So thank you, Debbie, and thank you, Dr. Kluger and Jennifer. Jennifer you're really a hero, and obviously inspire us all with your journey. You really, through clinical trials, and sort of rode the wave of success, even though, the initial antibodies didn't work, the cells did, and you sort of represent the progress that we're making. And Dr. Kluger, I mean, what a pleasure to hear your review. It brings back, I'm old enough to sort of bring me back memory lane, but I'm old enough to have been in the clinic with Dr. Chapman and colleagues, watching how chemotherapy really had no impact on the disease. And, I would see 4 to 6 new metastatic melanoma patients a week, and they were in their 40s and 50s, in the primes of their lives, like what Jennifer went through, and really telling them you had about 6 months to live. So I that's sort of a little PTSD for me, because I lived that for about the first half of my career, and then was lucky. And then we did do IL-2 based therapies, the kind of therapy you got as part of the cells that caused that reaction. And again, with those therapies, maybe 1 in 10 patients had long-term benefit, but at great cost. And as Dr. Kluger said, we couldn't really identify who would benefit. So it was a miserable time. And then ipilimumab, these newer T-cell antibodies, and then the PD-1 antibodies, really brought the survival curve from less than 10% to 20 to 25 to 50%. And that, I got to watch that in the clinic, and it was really an extraordinary time. It was like what I imagine those early childhood leukemia days, when all of the children died, and then 10% survived with high-dose methotrexate, and then 20 to 30% with chemotherapy, and then with bone marrow transplant, we're now at 80, 90%. That's where we're going with melanoma, but we need a lot of innovation and help, and the Melanoma Research Foundation obviously is a big part of that. So congratulations. I'm really focused now through Agenus as the Chief Medical Officer to really try to help us with Dr. Kluger and the other great melanoma researchers and patients. How do we go from that 50% to 80 or 90%? And melanoma has really been a prototype disease. And obviously these cells are potentially a big new option to move us further in that regard. But we're working on other drugs in my company and throughout the industry to really do that. And then we're also focusing outside of melanoma, but use the lessons learned there in other diseases that have never had a chance at immunotherapy. So a lot of work to be done, but I'm just delighted to hear this discussion and look forward to participating further with questions as thank you.
Thank you, Steve.
We have a question from someone who asked, has this therapy been trialed in patients with brain metastasis?
So yes, so this therapy, the cell therapy, was initially developed at the National Cancer Institute, starting in around 2004 or 5, something like that. They did the first couple of cases. And then in around 2015 or so, they looked back at all the MRIs of the brain, and they found that actually, in hindsight, some people did have brain metastases before they started, and brain metastases response in the brain is the same as in the body. So yes, it has been tried. There have been trials that are specific for patients with brain metastases. We have to be careful what we do when people have brain metastases, but yes, it can work sometimes, and it's been tried.
That brings up, I think, an important topic. As we develop these immunotherapies, side effects, if this was a sort of a T-cell activation, have been associated with some long-term benefit. In fact, patients who get side effects from immunotherapy do have a better long-term outcome. And this has been seen not only across melanoma, but other therapies. Obviously, we don't want people to get life-threatening side effects, but if we recognize them early, if it's inflammation at any organ site, it looks like intervening early and reversing that often correlates with a better long-term outcome. So it was an important concept, because with chemotherapy, obviously, if you're vomiting from chemotherapy, it doesn't mean you're going to do better or worse, but that's not the same with immunotherapy.
Yeah. And then Jen, there are two more questions for you. What year did you get treated with this? I presume it's the cell therapy.
That was 2017, and I remember it because that was when my daughter was going to college.
Yeah. And you started treatment in 2012? When was it? When we first diagnosed?
I think it was 2010 by the time everything got really rolling on it.
Yeah. Okay. What's your follow-up care now?
I have none, except for I get to visit my friend Dr. Kluger every 6 months. I get scanned. I get an MRI and a CAT scan alternately between my brain and my trunk. And then I talk to Dr. Kluger, usually by video. And she tells me everything's good, and we catch up on her kids, my kids, everybody's lives, and we go for the next 6 months.
Wonderful. Next question is, why does immunotherapy not work for uveal melanoma? You know, Steve, do you want to start with that, and I may add if or not?
Yeah. So, uveal melanoma obviously comes from the back of the eye and the choroidal area in the back, and this is a very rare subtype, and it's not. It's very different than skin melanoma in terms of its mutational burden and some of its sensitivity to immunotherapy. It also has a different metastatic pattern. It tends to go to the liver as a dominant organ after the eye, and it can go other places too, but liver is the dominant site. We've really struggled with this disease. The immunotherapies have not, the traditional ones like what we've talked about, with the CTLA-4 and PD-1 have not worked well in this disease. There is a new therapy that's been approved called a T-cell engager, and Harriet has probably more experience in the clinic with that than I do, but that's certainly making some progress. So I'll let you, and then the cells in terms of any of their abilities with this.
Sure. So no, thank you, Steve. So it's just, we don't really know why it works less well, other than that there do tend to be less mutations. So it's probably less driven by mutations, and it tends to be very aggressive. Sometimes it just grows so quickly that we don't have time to stimulate the immune system to treat it. But the drugs that what we just described, when you give the combination of the ipilimumab and nivolumab, or Yervoy and Opdivo, as they're called, you see responses in around 15% of patients, almost always patients whose uveal melanoma goes mostly to the lung and not to the liver, and the slower growing ones. So it does sometimes work. It's not like it doesn't work at all. It's just less good. The cell therapy, the type that Jennifer got, also will work sometimes in uveal melanoma. I don't actually know that we know the percentage. There's one trial that's being conducted out of Pittsburgh, which is specific for patients with uveal melanoma, and responses have been seen there. I just don't know. I don't know that the data have been published. I haven't seen it. And then there's this new drug that Dr. O'Day alluded to, the T-cell engager. So it can be used actually for uveal melanoma or skin melanoma. It's just that the company that developed it decided to proceed with uveal melanoma primarily because there was nothing else. There was no competition in that space, whereas skin melanoma, all these other exciting things were happening. So the way this drug works is that it's like an antibody that on the one side will bind to the melanoma cells, and on the other side will bind to those T cells that we have, and bring those T cells into the tumor microenvironment, for lack of such a simplified way of putting it. And if you increase the number of the T cells in the tumor microenvironment, and they actually kind of attach to the melanoma cells, they're going to start shooting bullets at the melanoma cells and whacking them. But yes, some progress has been made there. They're now modifying those and making new versions thereof. So I think this whole field of T-cell engagers is going to really implode in the next few years as well. We're looking forward to seeing many new products come through.
I want to be respectful of people's times. I know we're coming to the end of our hour, and I have a bit of closing remarks. But before we get to that, I have one other just quick question. that I really wanted to ask you. What are some of the lessons learned in these early immunotherapy trials compared to chemotherapy?
Yeah. Well, so thanks for the question. I mean, there were a lot. One that Harriet alluded to is that shrinkage of tumors, dramatic shrinkage is what we're going for because that correlates the best with long-term survival. But immunotherapy works also by stopping new tumors from forming, and patients can survive even with their tumors, even if they haven't completely gone away. And we learned that very different than chemo, where if you have to basically get all eradication to have any potential benefit. So that was a big one. And then the other was the timing of how quickly the response happens. Sometimes tumors grow in the first month or two and then actually shrink. And that was a different lesson with chemo. They either shrink or they don't, but it's very quick. And then finally, I think the third lesson is that side effects that I alluded to before can not desirable, but they can certainly, they mean that these T cells are moving around and they can cause mischief in other organs. And the fact that they're moving around is potentially a good sign that they could get to the cancer better. So I think those are three examples of very different paradigm shift from chemotherapy. In those early days, it wasn't obvious. So I really credit the team of melanoma investigators that were with me, and we sort of had to learn this as we went. And but now it's sort of much more obvious as we develop better immunotherapies.
Well, thank you guys. We did have one last little question that came through. If you could answer it quickly. We have any thoughts on why some respond to immunotherapy and others do not?
Do you want me to take it?
Yeah, take that, Harriet.
Okay.
Yeah.
No, sure. So there's a lot of work going on in the space, and there are many, many different reasons that have been described. There's not one answer that encompasses all patients. So sometimes the T cells just aren't there within the tumor, so there's nothing to stimulate. Sometimes the the tumor cells themselves create a rind around them. Not so much in melanoma, but you see this in pancreas cancer and in other diseases, and the T cells can't get in there. Sometimes there's an abundance of other kinds of immune cells that are suppressive in the tumor, and they basically counteract the activity of the good immune cells. So like macrophages, regulatory T cells, there are various names, and those can sometimes be incredibly suppressive. Sometimes the cancer cells just are so smart that they develop more of those inhibitory molecules on their surface themselves. So PD-1 is just one of those molecules, but there are another 15, 20 that have been, maybe even more, that have been characterized at this point, and they can overpower the PD-L1. I mean, I think those are the main mechanisms that have been described.
Well, with that, I would like to thank you all for joining us today, and especially to our speakers for presenting. We appreciate all that you do for the melanoma community and appreciate you taking additional time to be with us this evening. Thank you again to Agenus for their generous support to our Ask the Expert webinar series. Again, this program will be available on demand on our learning platform. The link is in the chat and we can put it in again. And also stream to our social media channels at a later date. At the end of the program, when you close your screen, there'll be a short evaluation that will pop up in your browser. Please do fill that out. It provides us with feedback on today's session and helps us create new programs for the future. Please visit melanoma.org to learn more about our upcoming webinars and other educational or advocacy opportunities. We have a ton of free resources that we offer to patients, caregivers, and healthcare providers, including educational literature, patient forum, Ask the Nurse hotline, and animated patient video series. So if you have any questions that you think of later, please email us at education@melanoma.org. And thank you again for joining us today.
Thank you, and
Thank
Jen,
you.
thank you, Steve. Thank you so much for coming on.
Thank you,
Debbie,
Jennifer,
thanks
for all
organizing.
you're doing too. Thank you.
Yeah. Thank you.